We are the PODdoctors. Welcome to the PODdoctors. I'm Dr. Damien Dauphinee. I'm here with my partner,
Dr. Raafae Hussain.
Hello. And Dr. Hussain, today we're going to talk about a little slip and fall injury. Good winter topic here. We're about to supposedly have snow this weekend here in the Dallas area. I don't know if the meteorologists are just teasing us or if that's actually going to happen.
Hopefully no ice.
Probably not enough to cause slip and fall, but there are clearly other places in the country that are dealing with winter weather, and this is a significant source of slip and fall, ankle fractures. So let's jump right in here and talk a little bit about common ankle fractures, symptoms that people would typically present with if they don't show up in the ER, and then what we do to work them up and what we do to fix them.
Yeah. So how do you discern ankle fractures from ankle sprains or twisted ankles or whatever you want to call them? They all present about the same: swelling, tenderness, pain, inability to stand upon it. It's just, your classic ankle injury. Now, with ankle fractures, this is my personal opinion, I typically see more bruising. I don't know what...
Maybe, but I've seen horrendous bruising from just a really wicked sprain as well.
Yeah,
and so, true. Patients always say if I can weight bear on it, it's obviously not broken, and that's clearly not the case.
No.
So we both have seen significant ankle fractures where the patient comes in and they've been walking on it for 2 weeks and the fibula is really not connected any longer. So, you could have a dislocation where you can clearly see the foot is no longer attached to the leg. That's not hard to figure out, and you've got some great little mini videos. Yeah, those are the easy ones. You're like, okay, yeah, that's fractured. We should probably go to the OR and fix that.
I one time had to close reduce an ankle fracture in office, and the lady had it for about 2-3 weeks, if I remember correctly.
Oh my goodness.
She fell in her backyard, just like pothole injury, and she presents. She's like, I've been trying to get around, and I definitely think it's broken. This lady, I kid you not, had like a 30-degree angle of where her foot and her ankle was. Jeez. I had a number up in office, close reduce it because the bone is pushing on that skin and getting her like that little black S-scar.
Sure.
Oh yeah. Yeah,
that's not typical. Usually the ones that walk in the office they think they had an ankle sprain, and then you get an X-ray and you realize, okay, they've fractured the fibula. And if it's well positioned, you can cast them and they'll do great. And if there's more than I think the literature would support more than a 2 millimeter deviation, then it's probably a good idea to take them to the OR and fixate that. Yeah.
So let's talk ankle anatomy. What actually makes up your ankle? So here, if you're watching the slides, you got the fibula on the lateral side of your ankle. The lateral side is the outside, and then your tibia, the medial side of your ankle. Also commonly referred to your medial malleolus and lateral malleolus. Those are the bumps on the outside of your ankle. Attached to those, you have a bunch of ligaments, but today we'll be talking about fractures and mostly the bony component of it, but you will see that a lot of ankle fractures that we treat do have a soft tissue component when we're talking about going in and fixing it surgically. Here's some X-rays. I got the lateral view right here. You can see the fibula behind the tibia, a little shadow. And when you're looking at these X-rays, you're kind of looking for a couple things. If something obvious is right there in front of you, obviously it's easy to see. But what we're looking for are little telltale signs, the small flex, the break in the cortex. That's the edge of your bone. Sort of think of it like
like an eggshell.
Eggshell,
mm-hmm.
Exactly. You're looking at that little pocket right here between your Achilles and your ankle joint, that Kager's triangle. If there's significant swelling, you'll see that completely obliterated. And then obviously gapping. If there's significant gapping between your tibia and fibula or between your tibia and your talus, then we obviously know there's something going on.
And the view on the right, the view on the right, if you saw, a medial deviation where you see the gapping broader at the medial side, you can point to that maybe. There you go. Yeah. If you see a medial clear space gapping there, then that talus is shifted. It's pushed the fibula. Then you look up the fibula, and if your picture's not going high enough, you may need to get a long leg view to be able to see the fibula higher up.
Yeah, and what Dr. D is talking about something specifically called a Mason-New fracture. I got a couple of pictures from that I think you're going to like.
Good. Those are fun.
So classification systems. I'm not going to go through and teach you the classification systems because it's not going to make a difference to you, but understand that there's two major classification systems that we talk about. The Dennis-Weber, which is typically used primarily for fibular fractures, and the Log-Hansen that we use because it actually shows a guideline of how the fracture progressed. So things that you may not see obviously on the X-rays, you may be able to catch up if you understand the
mechanism
of injury.
It's trying to marry what's happening with the bone to the mechanism of the injury, and that's why the Log-Hansen system is still used today.
Yeah, and this is typically commonly more used in adults. In children, we'll talk about the more common type of fractures. Quick slide on Dennis-Weber. Just like I talked about, the fibula, we decide if it's type A, which is below the syndesmosis, the type B, which is at the syndesmosis, which is the attachment of your tibia and fibula right above your ankle joint. Right here.
Yeah.
Oh, not showing it. There we go. And then your type C, which is higher up. And we can use this to kind of determine your Log-Hansen classification also. Log-Hansen, quick overview. If you're interested, look through the slides. If you're not interested, keep on listening.
There's probably a good YouTube video that gets more
sure.
in depth, but that from a patient's perspective, it's not that critical.
If you guys do want to understand this type of ankle fractures, let us know. I mean, I don't mind going through this stuff. This stuff is tons of fun, and I'll show tons of clips on people getting injured. So here's something that, typically presents. A patient came in, rolled their ankle, it's been bothering them, so we look at the X-rays. You can see the obvious fracture on the fibula. You see that gapping in that medial clear space that Dr. D was talking about, that shift, telltale signs. If you understand the mechanism of injury, then you're also looking for what progresses after in that Log-Hansen classification system. I have a little, cheat because I made the slides, so I know exactly where to look. But if you look at back here,
so that patient may have not only a posterior fleck, but also a deltoid ligament rupture. Yeah,
spot on. So, boom,
ding,
fibular fracture, that deltoid ligament tear. If the ligament didn't tear, the deltoid ligament, the one that makes up the medial malleolus to your talus, right here.
There you go.
To your and to your calcaneus. If that didn't tear, then your medial malleolus would break. That's where you have the obvious fracture on the tibia.
One or the other is going to happen with that kind of a force.
Beautifully done, whoever repaired this. Thin anatomic plate, lateral fibula, compression screw. People typically ask, what's that screw that's floating in there? That's your compression screw. That's literally bringing the fracture together.
Right. And your plate is simply a buttress.
Yeah. Hold it steady. And then they can see that they've reduced it well because that gap is gone now.
Mm-hmm. Now, that would be interesting to see a CT of, to see if they put the fibula back into the notch.
Yeah.
Yeah. But that's just a technical issue that plagues us consistently with ankle fracture repair.
So here's another example. Very obvious fracture.
Oh, yeah.
Look at that fibula, comminuted, that medial mal, transverse fracture.
Gapping.
Gapping.
That is going beyond the that's going beyond the osteocytic jumping distance. So your osteocyte's not gonna jump that distance.
So you can see this was beautifully done again. Fibular plate. This screw right here coming across the tibia and fibula. That's to reduce the syndesmosis. Sometimes people like to use the suture rope, the fiber wire. What's the one?
That screw's broken. Am I in the middle?
Yeah. So this is probably an older X-ray. So that's a very common question. So if you're using your syndesmotic screws and you're using one screw, I don't want to go onto my treatment plans, but typically I'll put a screw across there and tell the patients that it's going to break. It's known to break, very known to break. Sometimes people will put 2 or 3 across there.
So clearly that's a post-op film.
Oh yeah.
And we're seeing the fibula's healed at that point. So that's actually an expected result.
Expected.
Yeah.
Typically tell them about the 10 to 12 week mark. We'll go in, remove that screw, and if the hardware is bothering, we'll remove everything. It doesn't make a difference at this point because the bone's healed.
Right. Yeah, that's the other thing that people don't understand is, go back to that slide real quick, that once 6 or 8 weeks go by, all of that hardware is obsolete.
Yeah.
So we don't plan on taking it out, but there are certain times when the screw backs out or you start getting a prominence, or maybe a particular patient doesn't like the way it feels in boots that they like to wear, and we have to go in and
lateral
take it
fibula, very common. People will complain about it. So a lot of the anatomic plates will contour to the bone. Sometimes they'll be posterior, but the fibula doesn't have a lot of meat over it. So sometimes you'll feel it, and it's not unheard of to go in and remove those.
Right. But they're not really accomplishing anything once the bone's healed. They're just hanging out. Yeah.
Here's the Mason fracture.
Yeah.
Look at that video. Oh, yeah. Sometimes you'll have a patient come in, we'll do the X-rays, and you're like, oh, I don't see a fracture. But look at the telltale signs. You got that medial gap, that loss of syndesmosis apposition, and what you look for when you do your stages of fractures, you know that there's a tear across here. You know there's a tear across the syndesmosis. There's something going on with the fibula, but what is it? You get the high fibular X-ray, and you can see that what's called a Mason fracture. Now, there's arguments if you should or should not repair them. I'm not going to go into that, but there's your problem.
Yeah, I would, if they had perineal issues, if they had a nerve issue at that site, you might consider it. But
so if you remember our nerve entrapment conversation, video, lecture, podcast, whatever you want to call it, that common peroneal nerve palsy, where you get the foot drop we were talking about, that's how it could happen sometimes. That fracture, you get that deviation of that bone, or that bone callus, or that impingement for whatever amount of time, or surgery if you went in and fixed it. Very easy to injure
fibrosis,
that nerve.
just you get fibrosis in or scars in poorly. Yep. So that's definitely something that you need to look for weeks down the line.
Yeah, I bet you this lady won a bunch of money and paid for her surgery.
Does you're quoting the website there? Does that seriously say farticles?
Where does it say that? Oh my God. I literally copied and pasted it. I give credit where credit's due. It's an amazing farticle.
The F article. That's funny.
So types of fixation. This is just a broad overview. The before and after, plates, screws, these little tags that you see here on the side, that's that suture rope that we were talking about. I typically prefer the suture rope. I don't know if we should call it suture rope, the fiber wire, the tight rope. The tight rope is a brand name.
Yeah.
Suture button, whatever you want to call it. It just works well. The benefit of this versus screws is when you're using screws, you are set in a specific alignment, and you don't know if that fibula is going to reduce back into that groove where the tibia allows it to sit. Now, when you do that suture button, you're allowed a little bit of leeway whenever you're trying to compress those type of injuries.
Right.
But here's the alternative down here, the crossing screws. Some intense hardware on this one.
Yeah, and there are times in our diabetic population where we don't want to put in internal fixation. Maybe they've got tremendous swelling, or your skin envelope is cruddy. In other words, if you've got a patient who has pretty significant skin issues, you don't want to operate through that. If they have fracture blisters, you don't want to operate through that. So that's where that external fixator up top there. Those are great because you can temporarily fixate and allow things to calm down, allow the swelling to come down, and then decide if you need to go in and augment with some internal fixation. So,
yeah, just like Dr. D said, if you have an open lesion, we're trying to avoid surgery because that's risk for infection.
Right.
You can use that delta frame to get you that distraction, kind of hold that position well, and hopefully go back in later and appropriately, repair it. What do you think of this one? I put this one here for a reason. What do you think of that reduction?
That's terrible.
Yeah, so that's when we were talking about that proper reduction of that syndesmosis.
Those screws aren't probably big enough or long enough.
Yeah.
If you're going to use those as syndesmotic screws, they just didn't go far enough.
Or they probably didn't clamp it.
Yeah.
I mean, they might have just thrown it blind.
Right. Yep.
Here's a great reduction right here. Can't follow my mouse. This right here is a IM nail, intramedullary nail for the fibula. Works great. You're going to get great reduction of that fracture because you're literally going through its natural canal, your bony canal.
We used to call those, other than the fixation component, they used to call them rush rods, where you just go knock that rod up there. But the fixation that allows the stability for that particular product is great. Yep.
Yeah, these plates and screws and hardwares, whatever you want to call them, they've gotten so advanced. Before, you'd have to cut and mold your own plate. I remember when we had to do that back in training. Yeah, you had to literally bend your own plates, cut them to length. Oh, I need an 8-hole, but we only have a 12-hole, you know.
It's nice to have that perspective, though, because when we go to Mexico and operate, sometimes, we were dealing with less than optimal internal fixation options, and you have to be able to think on your feet and say, okay, I don't have exactly what I need. What can I use that will approach that and approximate that so that I get a good result regardless? And so I think that was always good for the residents to experience, that you're not going to always have everything you absolutely need. And you could have a case where stuff gets lost and doesn't show up to your case. And so, you need to be able to have backups for your backups. Yeah. It's just the reality.
Because the surgery has to get done. It has to be fixed.
Right.
What about hook plates? I'm a big fan of those hook plates. Before they'd even make them for the medial mal or the lateral mal, you'd have to cut the plates and bend the twines down, because sometimes that little avulsion would be too small to put a screw through, and you're like, should I do a K-wire? I might not get great reduction. Should I do, what's that called, where you do the crisscross?
Cerclage.
Cerclage wire.
Yeah.
We're
getting a little technical, but these are really fun to do, and they can be challenging because the fracture patterns can be very comminuted, or there can be multiple pieces, in other words. So this one on your far left here, that was a challenging fracture, I'm sure, because that you had comminutia or multiple pieces of the fibula, multiple pieces of the tibia, and syndesmotic injury. So that's a challenging ankle fracture to repair, but they're fun to do. Yeah,
and worst comes to worst, we can always go and replace the ankle joint.
Yeah, or fuse it.
That's not what you want to look forward to. I'm just joking. That's 100% a joke.
But again, you have to understand that once you've had a significant ankle injury like this, the joint's never going to be the same.
Yeah,
you're going to have
arthritis.
You're going to probably end up with some early post-traumatic arthritis, despite tremendous result. This on the far left, I wouldn't call that a tremendous result because of the syndesmosis has not been appropriately addressed. So that patient either is going to have that surgery augmented or redone. But, in most of these cases where they look like the internal fixation has been placed appropriately and you've got good alignment, these people are still going to probably have some issues with that joint down the line.
Yeah, it's not uncommon that I tell patients after we do an ankle fracture, maybe a year or so down the line, if you're having ankle pain, we may go in, scope out that ankle, clean up any of that scar tissue that might have formed there. If there's a violation of the ankle joint itself, there might be, micro drilling that we need to go in and do, osteochondral lesions that we need to fix.
Cartilage destruction. You could have subchondral bone or bone underneath the cartilage that's damaged that you need to address. So down the line, those cartilaginous or osteochondral defects are sometimes what really causes chronic pain.
Yeah. So after surgery, what are we looking at? Cast, very simple, very effective, works great at holding that correction. A lot of people have been shying away from cast, and I think for fractures, it's a phenomenal thing, even if only for the first few weeks. Holds that correction well, giving your hardware less stress.
Well, and whether you use a cam boot, which is a prefabricated cam boot, or you use fiberglass, probably doesn't matter, except I kind of make that decision based on the patient's personality and whether or not I can trust them.
Because a lot of patients think the cam boot means that you can walk in it.
Yeah. Or they literally don't wear it for a significant percentage of the day. There was a study that Armstrong and Lavery did on cam boot use. This was in diabetic patients, but they had a device in the boot and a device at their hip that was like a pager. and those two were connected electronically. And every time those two were more than, I can't remember how many feet, but let's just say 4 feet apart.
Yeah.
Clearly the patient didn't have the boot on because their leg was not 4 feet long, or 5 feet, whatever it was. And so they were able to tabulate all that data for weeks and weeks on a number of patients, and they showed that they only warm about 30% of the time.
Wow.
So, that's not going to be effective if you're trying to heal an ulcer, or if you're trying to heal a fracture, if you're only wearing it 30% of the time. So fiberglass is clearly a better option in most patients, I think, because they're not generally going to take it off. I've had a couple of patients who got it wet in the bathtub and unwrapped the whole thing, and they're like, because you get something called, we call it cage rage in internal fixation, but you can get a claustrophobia in some patients from being in a cast that they don't know what to do with. And if they don't tell you that's the problem, they're going to cut it off with a bandsaw, whatever it takes, which is kind of scary.
I've had patients use reciprocating saws, like the ones for drywall. I've had patients try to burn them off.
Oh, God. Yeah. So you need to make sure that you have that conversation with the patient, because, they might need, some vitamin X.
Yeah. You're not treating just the fracture. You're treating the patient.
Absolutely. And if they can't handle, a cast, then you need to kind of flush that out early on and not get surprised when they show up without it.
So here are some, other things that we typically talk about: crutches, knee scooter, the little peg leg device. I don't even know what it's called.
IGO or something. Yeah. I think people don't realize how difficult crutches are to use, even when you use them correctly. And I think the knee scooters.
Knee scooters great.
Knee scooters are great. And I like the IGO for younger, healthier patients who are a little more dexterous. I don't know that I would put an 80-year-old in.
No. I had a patient in it back when I was at the VA. Younger guy, had to be in his 50s or 60s, and young, he was athletic. He would play sports, and he used the peg leg, the IGO, whatever it's called, and he thought it was phenomenal. I mean, he would walk, and you wouldn't even tell if you didn't see his cast behind him.
Yeah,
it works great.
Yep, they do. I think there's a significant biomechanical advantage with those. Yeah, keeps them off their foot, whatever it takes.
So. Pediatric fractures.
Okay.
So typically we go with Salter-Harris on this because peds, your younger population, their growth plates are still open. Mm-hmm. So it's a very weak spot or a common spot for injuries. And aside from that, if there's an injury to the growth plate, we're talking about, possible future problems. If it's an angulation or an arrest of the growth plate where it kind of grows slower than the opposite side. So it's something that we kind of take
crush injuries, you could have it just shut down, and the patient would end up with limb length discrepancy because of it.
Yeah, and same thing when we're talking about going in and fixing these patients. If they have a fracture that violates the growth plate, we try to put the fixation away from the growth plate. We're trying not to go across the growth plate. I think the rule of thumb is if you're doing anything fixation-wise that violates the growth plate, use K-wires.
Right, smooth K-wires that don't cause compression. Mm-hmm.
So... simple example.
That's awful. Oh, jeez.
Poor kid and his cat doing a little parkour, falling face first.
I hope he survived that. That's awful.
They say that if you go down those stairs, he might still be laying there today.
Oh, man.
So here's a little ankle fracture.
There's your growth plate, and you're keeping your screws away from the growth plate.
Yeah, simple, effective. Nice. This is a Salter-Harris type 4. For any of you who are following along. Here's another example. You can see the comminution through the fibula, and then you see that tibia right there. And then when you get that lateral, that's why we get multiple views. You get that little blowout through the back. This doc went ahead and got a CT scan, and they can see the fracture a lot more accurately. And that's why this patient has 3 screws, in the tibia, one lower, one higher, to get that compression across that fracture site. And then obviously for that fibula, one of those straight plates. And as you can see the plate, these are one of the older plates. That's why we call it a square plate.
Yeah, old Synthes stuff.
Yeah, works great.
Stainless steel.
Here's another fracture. Fibular fracture, oblique, and your tibial avulsion fracture. Now, this is kind of a little trick question because this is not a Salter-Harris type fracture. This is a avulsion type fracture. There's no violation of the growth plate, so luckily the patient didn't have to worry about all that. But when we're talking about fixation, you can see the K-wires crossing the tibia growth plate and the fibular growth plate. But I'm sure this patient healed up uneventfully. Classic fixations for peds, just like we said, K-wires, smooth wires across the fracture site, across the growth plates, because we don't want to be the one injuring the growth plate.
Right.
Delta frames, sometimes used in children to avoid those growth plates, because sometimes they're comminuted and we want to put plates and screws across them, but it's safer to distract and use that delta frame or external fixator. And then obviously casting your patients. I think cast and peds work a lot better than boots.
Yeah, absolutely.
Well, I mean, as far as ankle fractures go, I try to keep it real straightforward. I did a little bit of...
We got a little technical there because they're fun to talk about. They're fun to do. But I think some of the salient points would be that if you can walk on it, it doesn't mean it's not fractured. That is a huge misunderstanding of what's going on. That it is important, even if you've had surgery and internal fixation, to listen to your surgeon and make sure that you stay off it for an appropriate period of time, which could be 4 weeks, could be 6 weeks, could be 8 weeks.
Yeah. I tell patients 6 to 8 weeks on average.
Yeah.
And if it's a large fracture, older patient, poor healing potential, I mean, I tell them up front, this might take up to 12 weeks.
Yeah.
We'll get serial Xrays. Sometimes we'll get a bone stim if needed. There's a lot of literature out there as far as like supplements, calcium, vitamin D, whatever you want to take. I mean, I just tell them, take everything. There's no harm in taking these type of things.
And there are some patients that we clearly probably should run vitamin D levels on.
Yeah.
And you know, I do that from time to time using supplements as well.
I used to prescribe like Forteo and things like that if they were like osteopenic, but now I've kind of trended away from that and let their primary take care of that stuff because they've been following them for longer.
Right. I think the other aspect of this that's important to note is that most people will lose about a percentage of their bone mass every year after the age of 35. And so if you're, 65, 70 years old, you've lost potentially 35 or 40% of your bone mass naturally, even if you don't have osteoporosis, which would be, an extension beyond that 1% per year. And that, so it's not a negotiation when we tell you this may take 4 to 6 weeks. We had the ability to make bone heal faster. We could win the Nobel Prize. So short of that, it's based on X-rays when we're going to allow you to weight bear on this. We have to see some sort of evidence that there's bone healing occurring in such a way that we can assure that you're not going to make things worse by weight bearing on it.
I read this article that this doctor made this bone glue that I guess it has osteosynthetic properties, which you literally put across the fracture site, hold it in place. I don't know what the wait time is, but I'm sure it's short compared to bone healing. And it's supposed to be something in the works right now. They said that they don't expect it to be, on the market, FDA approved for the next 5-10 years, but might be something to look out for.
Yeah, that sounds interesting. I know they're using synthetic bone substitutes in Charcot patients, so that you inject right into the Charcot bone that's supposed to stabilize the bone. One of my colleagues, Andy Rader, has been doing a bunch of that up in Indiana.
Oh, wow.
He does a lot of external fixation and Charcot reconstruction and uses that to stabilize the Charcot bone. So that, that's really fascinating and interesting as far as ankle fractures. So ankle fractures in diabetic patients are kind of a different, sometimes a completely different animal.
Yeah. If they have neuropathy, peripheral arterial disease, slower healing potential pretty much.
Well, and you have to consider some of them to actually be Charcot injuries.
Oh yeah.
Right. So those are extremely challenging. We're much more likely to use external fixation in those patients because we don't want to violate the skin envelope. We don't want to make big incisions and deal with wounds that are going to be hard to heal anyway. And that's where, external fixation using Ilzaroff circular rings, I think is really helpful. And that's what I have chosen to use for the most part in diabetic ankle fractures.
Yeah, we'll do a lecture on one of those if you guys are interested.
Well, we're heading that direction. We got to do a Charcot lecture here soon because I think it's a really fascinating aspect to our diabetic limb salvage care.
More prevalent than people realize.
Right. Mm-hmm. Very good. Well, I think that is a great primer on ankle fractures during the winter, the slip and fall injury that it is. So if you have an injury like this, look for your local pediatric foot and ankle surgeon and get it checked out because you just don't know until you get an X-ray. Thanks again.
Be safe, guys.
All right, take care. This is the PODdoctors. Bye-bye.
Bye-bye.
We are
the
PODdoctors.